The first presentation with Dr. Samresh Srivastava and advanced preoperative diagnostic, how much is enough? Samresh, if you can restrict to 10 minutes or 12 at the maximum, please.
Sure, I'll try to keep it in time. Again, thanks a lot to AIOS and the faculty for inviting me for this talk on advanced diagnostics. Just a second. Yeah. We need to understand before we start the talk and whether, number one, is there a special need for any refractive cataract surgery at this point in time? How to go about it? And does it enhance our practices in our day-to-day clinical scenario? I'm going to be just discussing the diagnostics we use in our clinic routinely and nothing more than that. So in our clinic, we tend to have a dedicated team for a preoperative workup, which obviously consists of an optometrist, a technician, counselor, apart from the operating surgeon or a doctor who can explain all the same to the patient. But more importantly, we decide to dedicate a different time slot for a preoperative workup, which essentially means we call these patients mostly in the lean time of the day, which is the afternoon, where the entire team is dedicated to delivering the right outcomes, the right time frame, and also not having a rush up with the patient at that point. Like always, I think most clinicians would do, it's best to evaluate both the eyes at the same time, visual acuity, and evaluate not only the visual acuity, but all the parameters for both the eyes together at the same time. Now, in the industry, we realize that there are so many diagnostics and all trade fairs are completely full of newer machines. So it lands up to us to understand what works best for us in our clinical practice and not to just go by other people's assessments of different diagnostics. So the first thing that we look at in our clinic, which is I think sometimes underrated but extremely important, is assessment of dry eyes, because that's the first refracting surface of the eye. Because if you don't get that right, anything you do inside the eye is not going to do any good, because the light's already started to scatter. I mean, initially it used to be tear film breakup and Shermer's, but we don't do that anymore in our clinic because of paucity of time, and also it's a little more invasive. But what I've learned the hard way is to look at the lid margins and the tear film and the lid morphology, which I neglected for so many years and burned my fingers, because these were the patients that were unhappy despite a good surgery, because the problem was somewhere else and that was causing a dry eye in their eyes. So again, apart from the potential concerns of delayed wound healing, infection, and obviously delayed rehabilitation, there is a big concern of an unreliable biometry with the dry eye. And again, it's easy to understand that if you get this right, that the tear film is the refracting surface of the eye, the first refracting surface of the eye, you understand that an irregular tear film will obviously add to not only irregularity in the vision, but also irregularity in measurements. So this patient, if you look at, the patient came to our clinic and somebody has done an aberrometry. So this is just a topography showing a high astigmatism, and you can make out distorted Meyers, which are not visible actually on data. But the moment you treat this patient with a lubricant eye drop, as you see over here, let the tear film stabilize for 10 minutes and repeat the topography, almost nearly the astigmatism disappears, showing you how important the tear film is. But not only that, it also boils down into IOL power calculation. So when we calculated the patient's IOL power, we were getting a 20 diopter with the previous run of diagnostics. But the moment we lubricated the patient's eyeball and waited for 10 minutes, the biometry dropped by 1 diopter because the K readings changed. And if we were to implant a lens based on this assessment, which was the initial assessment, because the technician did not pick it up and it was picked up later by the doctor, the patient would have been landed with the biometric surprise of 1 diopter, which would have been very embarrassing. So it's very important to get the tear film right. And for this, very important, look at the Meyers of your topography that you're doing, but also look at the tear film breakup time. Now, again, it's very difficult to do it clinical scenario. I've used with the help of Dr. Himanshu Matalia, who exposed me to it, that's in tear film. But also newer topographies also have something very interesting called meibomian gland function. These are the dedicated meibomian gland machines that are there in many centers, some of the really good centers, including Narayana Nethralaya, which give you a very objective assessment of the lipid function of the eye. But even if you're buying a simple topographer, and so these newer topography machines do have lipid analysis. And so it's very important that when you look at these machines, don't only pick up a topographer for its topography, but see what value or what benefit it adds to your clinic. Again, AutoRef, one more way of looking at meibomian glands, but doesn't quantify. So it's not really something that you can quantify. Moving on from the tear film to the cornea, anterior corneal curvature has always been of paramount importance, but now posterior corneal elevation, posterior corneal curvature is starting to catch up more and more, because we've realized that posterior cornea plays a very important role in calculating the IOL powers. Scheimpflug is a way of measuring the posterior cornea, and now OCT-based topographers are coming. So this is the anterior cornea, which we've always measured with a placido topographer or with a manual keratometry. And that's the posterior cornea, which we had missed out for so many years. And over the last decade, a lot of knowledge has been generated, and a lot of understanding of posterior cornea has turned up. Just to show you a topography map from Scheimpflug imaging, shows you the pachymetry, which is very good because it tells you the overall picture of the cornea, but it also gives you the anterior and posterior keratometry readings, so that you can make out if there is anything happening on the posterior cornea. Also, there is a lot of data available now. One needs to decipher this data based on their preferences, but I would always look at the anterior and posterior cornea K readings just to understand whether the posterior cornea follows the anterior cornea or whether something is happening at the back. It has been shown that residual astigmatism can be reduced by considering posterior cornea. So biometric surprises or toric surprises that do turn up sometimes could be attributable to the posterior cornea, which was not factored in previous IOL power calculations. But the good news is that 90%, almost most of the eyes will be okay if you don't do a posterior corneal estimation. And that's because anterior cornea generally tends to compensate for it, and newer IOL power formulas also tend to compensate for that. Again, for us, corneal astigmatism is one of the best clincher in diagnosis. So this is just to show you that even if you do a simple test like a manual K, do it right. If you do an immersion biometry, make sure that you're aligned to the patient's visual axis. Shift from contact to immersion biometry because there is a fixation target. But very importantly, if you can, and this is the right time to upgrade, shift to an optical biometry. Optical biometry or an OCT biometry or a Fourier domain, whatever is new. If you've now not shifted to any of these biometers, I think it would be a time is appropriate because the market is right and the patients do want better visual correction. It's important because this has distance fixation and the patient can fixate on the visual axis, giving you very good measurements with the visual axis. Newer advancements into biometries are swept source OCT. We have experience with the TOMI, which is at our Ahmedabad center. We decided to compare these two different principles, the OCT versus the optical biometry. And we found out that with the Lenstar, which is our optical biometer, we were able to get it in almost about 90% of the eyes. But in TOMI, almost all eyes, just short of fully mature blown cataracts, we were able to get axial length measurements. So which goes on to show both are good, but maybe OCT biometers have a little more penetrability, a little less number of patients sitting in and undergoing contact or immersion biometry. When we look at formula for IOL power calculations, I think our go-to formula has been for the last few years, a Barrett Universal 2 formula. We've also looked at the Hill RBF formula, but because the Barrett formula is very well incorporated into the newer machines and it's extremely predictable, we tend to rely very heavily on that. We published this from our team in British Journal of Ophthalmology in 2020, where we compared the IOL calculation methods after LASIK and radial keratotomy, where we had no idea of what the prior refractive data was. This is how we use the calculator from the ASCRS, which has all formulas. This is available for free for anyone who wants to do a post-refractive surgery IOL calculation or an RK patient. This formula is available for us for free. And so is a Barrett True K formula, which is also available in the APS-CRS website for free for everyone to use. And we found out that in LASIK, although all formula did very well, highest number of patients within a half a diopter residual were with the Barrett True K method and also with the Sharma's formula. Good part, like I said, with the newer formulas is they come integrated into your biometer. So when you get a biometric printout, you also get the axis and you get a visual representation of where you have to put the IOL, which I think has reduced the workload significantly and made life really easy for us. And it makes data entry errors almost nearly impossible. Shifting gears from role of topography to aberrometry. Now, aberrometry is a gray zone when not everybody would want to invest in a machine like this. So I'm just going to be discussing based on my experience with the ray tracing aberrometer, which is the eye trace. It gives you a lot of data. Because it has a topography, it gives you a corneal profile. And because it has a ray tracing aberrometer, it gives you an internal profile of the eye, which essentially would mean the internal optics of the eye and in most likelihood, the lens of the eye. I'm going to skip out of this in the interest of time, just to show you a few examples on how it helps. So here's a 47-year-old female who comes to us with a 6x6 vision with a distinct complaint of being unable to drive at night. Mesopic pupil shows to be fairly okay, but when you dilate, you can make out that there's a cataract developing at the extreme periphery. Now, this should not cause a problem in mesopic vision. So we run the patient through an aberrometry, and you can make out that there is a huge aberration profile of a spherical aberration, which is turning in. A spherical aberration profile in the optics of an eye with a pristine cornea indicates that something's going wrong with the lens. So clearly, when we put the patient on a mesopic vision, we realize that this is what the patient sees in the mesopic semi-dilated pupil state. But the moment we'll turn on the lights of our clinic, we can make out by analysis that the pupil becomes small and you have a pinhole effect and the patient is 6x6. And this is where we are assessing the patient, and that's where the patient's complaints are. Pentacam gives you a very good assessment of a nuclear sclerosis. So this patient was obviously developing a nuclear sclerosis, which was not being picked up on slit lamp. We had an initial series with Dr. Rohit in Narayanathala, where we actually used to call it Zernicke cataract, but now there are fancy terms for it also. So you can pick up outliers like this. Outliers like patients who wanting cataract surgery and need toric IOLs can also be picked up. So this is very interesting to show that this patient shows no astigmatism on an entire eye profile, but there is a corneal astigmatism which is very clearly visible even on topography, which is completely balanced off by the internal optics of the eye or the lens, which is giving rise to a no astigmatic profile in the patient's refraction. Now, if you were to tell the patient to get a toric IOL, most patients will not agree because they think they don't have a cylindrical number. But showing them good diagnostics like this will maybe help you in picking up these patients and explaining them that they're in desperate need for getting good toric IOLs. I'm just going to move on out of this to more relevant point just to save on time. So it's very important as cataract surgeons that we just don't look at the cataract alone, but also pay attention to the posterior segment of the eye. So nothing beats a good indirect ophthalmoscopy and a good retinal evaluation. But I think nothing also beats an OCT in today's date and time, and particularly if you're targeting emmetropia and targeting premium IOL practice. So again, our group under the guidance of Dr. Sudhalkar published a very interesting publication where we did a prospective observational case series of patients whose one was undergoing a nuclear sclerosis or PSC cataract and had no history of any other comorbidities, retinal or systemic. These eyes were subjected to an OCT and it was independently seen by an experienced retinal surgeon, and the surgeon was masked to the OCT finding. So the retinal surgeon did not know what the OCT picked up, and this was a large number of eyes, about 220 eyes, all age-related cataracts, and no systemic history, like I said. And the amount of diseases that we picked up, subtle diseases like epiretinal membrane, RP irregularity, was quite alarming. So again, in a normal-looking fundus, an epiretinal membrane or a breach or a irregular fovea with a lamellar macular hole, RP irregularities, which can give rise to subtle problems, vitreomacular tractions, foveal thinning, and so on and so forth. And these were the patients that were not picked up by clinical assessment. So it goes on to show that it's extremely important to pick up patients and use OCT as a cataract surgery tool and a refractive surgery tool as well. But at the end, it's the art and science of evaluation. And so no matter what diagnostics you use, please spend enough chair time with the patient to first understand the diagnostics and then to explain to them so that they can make intelligent decisions, not only based on their finances, but also based on their lifestyle requirements. Because once they make this decision, it's going to stay with them for life. Thank you.